have the task of talking about brachytherapy in the spine. This is something that we have a particular enthusiasm for. I'm going to start with a quick case, 60-year-old with metastatic cholangiocarcinoma, first in 2009, had a history of 2 weeks of progressive mild back pain requiring narcotics, not mechanical pain, and the MRI shows this T9 sclerotic lesion here. And this is it on sagittal and T1 axial imaging. This patient was discussed in our multidisciplinary spine tumor board. Without mechanical symptoms, we felt this no significant epidural disease. We felt this is a good radiosurgery case, and so we treated this patient of 24 gray in a single fraction in September of 2009. Patient had very good clinical outcome, tolerated treatment very well, no complications, and was stable on MRI imaging on subsequent follow-up. Was typically what you see with these bone diseases. However, after about a year and a half, the patient had a return of original symptoms and had MRI imaging that a year and a half after radiosurgery had clear recurrence. Now has circumferential epidural disease that you can see here on this scan. But systemic disease is otherwise well controlled, which is really unusual for cholangiocarcinoma. This patient's done quite well, except for this local recurrence. And so now the patient comes back to our clinic, and we're wondering, now what? This patient has failed 24 gray in a single fraction. So, what could we do for this patient? This is not an unusual story in the epidural space. This is a paper we published now a number of years ago on our failure analysis of radiosurgery patients, and we found that the epidural space, which is the space of significant dose fall-off in order to protect the spinal cord, is really the predominant pattern of recurrence for radiosurgery. And we believe it's because of this steep dose fall-off. For example, here's a case of a patient who received 18 gray. The original target volume is outlined in green, and that was the target volume. So you can see we actually didn't even target this area, and this area ended up being the area of recurrence, and so recurred in the low dose zone, which is pretty typical. Treating around the dura is always an issue for radiation because of the proximity of the spinal cord, and it's a high-risk area for recurrence. It's very difficult to give doses of radiation enough to sterilize the epidural space because of its proximity to the spinal cord, particularly in cases where the spinal cord has already received a high dose of radiation. This led us to think about why not use brachytherapy as an approach to improve the dose distribution in the most vulnerable area. Brachytherapy is Greek for short, so it's the opposite of teletherapy, which is what external beam radiation is, where the radiation source in teletherapy is a meter away from the target. In brachytherapy, the source of the radiation is within the tumor, and short distance, therefore the term brachytherapy. It's ideally suited for very intense focal treatment, particularly when you use radioactive sources that are also very low distance sources, such as yttrium or 90 or phosphorus 32. These isotopes only have a range of millimeters. Plus, with brachytherapy, well, if any type of radiation actually, there is an inverse square fall-off relationship of dose and distance. That means that for any given distance, the dose of radiation will reduce in an inverse square relationship to the distance. If it's teletherapy or external beam radiation, if you have a dose at 99 centimeters versus 100 centimeters squared, that's actually very little difference, and so the dose fall-off is not significant. But if you're talking about a difference between 1 centimeter and 2 centimeters, that's a significant difference, because that's 1/2 squared. And so because of this inverse dose square-off, brachytherapy is well suited for very focal treatment. And we thought that this would be a very good strategy in the setting of recurrent disease, especially disease that's proven resistant to conventional radiation therapy. And it's a way for us to reduce the dose to nearby structures such as the spinal cord when we're treating the dura, the esophagus, etc. There is a very small body of literature on brachytherapy in the spine. Most people have reported the use of iodine-125 seeds. These are the same seeds that are used for prostate brachytherapy, very commonly done in the United States. And Tom Delaney's group in Boston have reported the use of iridium-192, and they've also reported the use of yttrium-90, which is a pure electron-emitting isotope. And in fact, this idea really intrigued us, and Dr. Bilski and I went up, I can't remember when it was now, but we actually went up to MGH to watch them do one of these procedures. And this is how they would do it. They have a yttrium foil. It's very, very fragile. It has to be put inside of a polycarbonate case. But because it's an electron or beta emitter only, the polycarbonate is enough material to absorb almost all the radiation. And so it's very safe in terms of radiation protection for perioperative staff. And the yttrium was placed in the inner surface of this polycarbonate case and then placed directly onto the exposed dura and then treated to a specified dose. We thought this was a great idea, but there are a number of problems with yttrium. First of all, the half-life is extremely short. It's only a couple of days, and so if your case gets canceled or delayed a few days, the yttrium is no longer usable because it decays too quickly. We actually thought that phosphorus 32 would be a better isotope, but we really thought that their idea was really brilliant. These are dose depth curves for different isotopes. This one is iridium-192. What this means is that this is the percent of the dose over the distance away from the source. So each one of these lines is half a millimeter. And so when you're getting about 3 or 4 millimeters away from this, let's say from the surface or the dura, with P32, which represents this light blue dose depth curve, the radiation dose is less than 5% of the surface dose. But for iridium, the dose is actually still 70% of the surface dose. If you had the spinal, let's say spinal cord margin is 4 millimeters in the lumbar spine or in the high lumbar spine, for example, where you have quite a bit of space, or even in the cervical spine, you often have quite a bit of space, 3 or 4 millimeters from dural edge to spinal cord edge. P32 would deliver only 5% of the dose or less to the surface of the spinal cord, whereas iridium would give 70% of the surface dose. With P32, it has a 2-week half-life, so if your case gets canceled for a number of days, it has a much better shelf life and is more usable, doesn't require any special shielding, and is a very high dose rate source. And so you can give the equivalent to a radiosurgical dose in the operating room with P32 in about 10 minutes. You can give an equivalent dose to 24 gray in a single fraction to the dura. So this is the way we opted to go, modifying the MGH idea. We feel like this is a better mousetrap. The P32 is bonded to a very thin plastic polymer. It's 1/3 of a millimeter thick, so it's a little stiff, but it still is pliant enough that it can provide good surface contact with the dura. It's applied intraoperatively directly onto the dural surface. It can be handled without any shielding, and we custom order it to a size that we feel is necessary for the time of surgery, and it's very easy to estimate what the reconstituted thecal sac will be after surgical epidural decompression. We simply have to look a level above or below the area of thecal sac compression, for example, and we have a pretty good estimate of what the reconstituted dimensions of the thecal sac would be at the time of surgery. So this case with the cholangiocarcinoma is reviewed. We opted to offer this patient separation surgery. Because of the circumferential disease, we felt that intraoperative P32 would be an excellent adjunct during surgery. And so here's the actual myelogram, postoperative myelogram. We contoured in the exact location of the P32, and we incorporate the radiation dose from intraoperative brachytherapy into our treatment planning for postoperative radiation salvage treatment. We did an interesting study to try to determine what would be the difference in dose distributions with or without P32. So here's this case with P32, which means that our target volume is now more of a typical horseshoe-shaped target volume that we typically would do for a postoperative case that wasn't circumferential. If we had to treat circumferentially around the spinal cord, then the target volume would be this red volume here instead of this horseshoe-shaped volume. And in order to get circumferential dose around the thecal sac, this is a much more daunting task from a dosimetry perspective. The reason why this is so difficult is that it's the crucial area around the epidural space that dose has to be sacrificed, especially in the setting of prior radiosurgery. Here are the differences in the dose coverage. This is a dose volume histogram, or a representation of the cumulative doses that given to different volumes within this patient. The difference between the dose volume histogram or target coverage with and without P32 actually isn't that remarkable on the dose volume histogram itself. There's only a small difference, but what that difference represents is that critical area around the epidural space, really the most at-risk area for recurrence. However, in every category, when we looked at our cases with or without P32, there was significant improvement in dose coverage for every parameter that was evaluated with the addition of intraoperative brachytherapy. Just to give you an idea of who we use this for, here's our first 12 patients that we did. Without fail, every single patient had either high-dose single course of radiation, this patient had 72 gray, or multiple courses of radiation and had failed radiation. And we're now looking at either repeat radiation for the second or the third time. I also should mention that all those lesions were, by definition, radioresistant tumors. This is a publication from last year, or 2 years ago now, I guess, excuse me, of P32. And this is our relapse-free survival for patients with brachytherapy. And so we're able to salvage a significant proportion of these patients who have been previously heavily treated. In fact, another interesting thing we looked at is patients who had so much radiation or they only had epidural recurrence that we felt all they needed was epidural treatment. And so the difference between patients who had postoperative salvage external beam radiation with P32 or, in the dark blue line, the patients who just had dural brachytherapy without additional external beam radiation, we're still able to salvage about half of our patients who just had a little bit of radiation to the dural surface. 50% of those patients were able to achieve long-term durable tumor control. So in summary, P32 brachytherapy is high-dose, short-range therapy. I forgot to mention that we haven't seen any complications from this, and we've treated over, I guess at least over 120 cases now. It doesn't require any special shielding. This can be done in any operating room, And I think the fact that we can locally control tumors with just epidural treatment in some cases suggests that the dural margin really is an important area of concern for tumor control, particularly in the recurrent setting. We're getting way behind schedule, so I think I'm just going to stop there.